Indication: cabozantinib, in combination with nivolumab, is indicated for the first-line treatment of patients with advanced renal cell carcinoma, RCC. Select important safety information. The full prescribing information for CABOMETYX includes warnings and precautions for hemorrhage, perforations and fistulas, thromboembolic events, hypertension and hypertensive crisis, cardiac failure, diarrhea, palmar-plantar erythrodysesthesia, hepatotoxicity, adrenal insufficiency, proteinuria, osteonecrosis of the jaw, impaired wound healing, reversible posterior leukoencephalopathy syndrome, thyroid dysfunction, hypocalcemia, and embryo-fetal toxicity. Please see important safety information at the end of this video.
Hi, I'm Dr. Katy Beckermann. I'm a genitourinary medical oncologist.
And I'm Dr. Elizabeth Wulff, also a genitourinary medical oncologist and a palliative care physician.
Today on CABOMETYX in Conversation, we're discussing a hypothetical patient named Marie. Marie was newly diagnosed with advanced renal cell carcinoma, or ARCC. You may have seen Marie's case discussed on a previous CABOMETYX in Conversation video, but we want to take a look at the treatment decision again in light of data shared at ASCO GU 2025.
Marie is a hypothetical 69-year-old female patient who presented to the hospital emergency department with complaints of shortness of breath, fatigue, and back pain. She has a history of tobacco use and quit 5 years ago. Her medical history includes hypertension and osteoarthritis that are well controlled. Her physical exam was unremarkable, but CT findings revealed an 11-centimeter right renal mass that extended to the renal vein and multiple metastases to her bones, liver, and lungs. The biopsy findings from the renal mass showed a grade 3 clear cell renal cell carcinoma. In sum, Marie is a 69-year-old female with hypertension and arthritis who presented to the emergency department with symptoms caused by her newly diagnosed kidney cancer metastatic to lungs, liver, and bones.
As we will see, there is strong evidence to support the use of CABOMETYX plus OPDIVO in a patient like Marie. Dr. Wulff, the clinical trial leading to the approval of the regimen was the CheckMate-9ER trial. CheckMate-9ER was a large phase 3, open-label, randomized head-to-head trial. It enrolled 651 patients who had previously untreated advanced renal cell carcinoma with a clear cell component. Patients received either CABOMETYX 40 milligrams orally once daily plus OPDIVO 240 milligrams IV every 2 weeks, or sunitinib 50 milligrams orally once daily for 4 weeks, followed by 2 weeks off. They were treated until disease progression or unacceptable toxicity occurred.
The primary efficacy endpoint in CheckMate-9ER was progression-free survival. The secondary endpoints were overall survival, objective response rate, and safety. PFS and ORR were assessed by blinded independent central review. Also, quality of life was an important exploratory endpoint that I'll talk about later in relation to this case.
We saw new data this year at ASCO GU 2025. The initial primary analysis had a median follow-up of approximately 18.1 months. However, the most recent data presented provides us with a minimum follow-up analysis of 5 years, and those are the data we will review with you today.
Patients like Marie, who were included in this trial, are similar to those you might see in your waiting room. Most patients enrolled in CheckMate-9ER had 2 or more sites of metastases. If we look at the breakdown, 75% of patients enrolled in CheckMate-9ER had lung metastases, 23% had bone metastases, and 19% had liver metastases. Marie also has a prognostic score of IMDC poor risk, and 78% of patients enrolled in CheckMate-9ER had an intermediate or poor score. Now let's review the efficacy results of CABOMETYX plus OPDIVO from the CheckMate-9ER trial. Just taking the primary endpoint from the initial analysis of the ITT population, you can see that CABOMETYX plus OPDIVO provided a median PFS of 16.6 months, double the 8.3-month PFS that was seen in the sunitinib arm.
And those results were sustained in the latest 5-year follow-up analysis. In this analysis, the median PFS in the CABOMETYX plus OPDIVO arm is 16.4 months versus 8.3 months in the sunitinib arm. It's important to mention that there was no formal statistical testing conducted at the time of the updated analysis, which is typical for long-term follow-up data. The overall survival data in the primary and 5-year minimum follow-up analysis also support the use of CABOMETYX plus OPDIVO for Marie. In the primary analysis, the median overall survival wasn't reached in either treatment arm, but the hazard ratio was 0.60, with a 40% reduction in the risk of death. And in the latest data from the 5-year minimum follow-up analysis, the median overall survival was 46.5 months with CABOMETYX plus OPDIVO versus 35.5 months in the sunitinib arm. The hazard ratio was 0.79, corresponding to a 21% reduction in the risk of death.
I also mentioned that Marie had metastases in her bones, liver, and lungs. Another consideration for prescribing CABOMETYX plus OPDIVO for Marie is that the 5-year minimum follow-up analysis contains overall survival data for patients with each of those types of metastases. In patients with bone metastases, the median overall survival in the CABOMETYX plus OPDIVO arm was 34.8 months versus 20.7 months with sunitinib. In patients with liver metastases, the median overall survival in the CABOMETYX plus OPDIVO arm was 37.6 months versus 22.1 months with sunitinib. And in patients with lung metastases, the median overall survival in the CABOMETYX plus OPDIVO arm was 47.5 months versus 32.4 months with sunitinib. As with the other overall survival data you shared, no formal statistical testing was performed, and because this is an exploratory analysis, the subgroups were not powered to show differences between treatment arms, so the results should be considered hypothesis generating. For your harder to treat patients with multiple sites of metastases, it's helpful to have these data to consider when evaluating treatment decisions.
So I think we both agree there is compelling efficacy data for using CABOMETYX plus OPDIVO for Marie. Marie also has several comorbidities, so efficacy has to be balanced with safety. In the primary analysis of CheckMate-9ER, the adverse reactions with the highest incidence relative to sunitinib were hepatotoxicity, rash, pruritus, and diarrhea. The most common grade 3 or 4 adverse reaction was hypertension, with an incidence of 13% with CABOMETYX plus OPDIVO versus 14% with sunitinib. The most common adverse reactions were grade 1 and 2. You also have to monitor for toxicity in the form of abnormal laboratory values. In CheckMate-9ER, the top 3 all-grade lab abnormalities in the CABOMETYX plus OPDIVO arm were increased AST, ALT, and hypophosphatemia. But I think it's important to do full panels and check how everything is looking over time.
There's one final data set I like to consider when we think about Marie's treatment, and that's quality of life. My background as a palliative care physician, as well as a genitourinary medical oncologist, provides a unique perspective on meaningful insights into the overall impact of both the disease and treatment. It helps us understand how a therapy affects a patient's physical, functional, emotional, and social well-being over time. This is helpful when assessing treatment. In the CheckMate-9ER study, quality of life was assessed in exploratory analyses, and the clinical significance is unknown. One analysis used a questionnaire called the FACT Kidney Symptom Index, or the FKSI-19. Patients responded to statements across 7 domains, including their disease symptoms, adverse reactions, and general psychosocial functioning. These responses generate a score between 0 and 76. The higher the score, the better a person's quality of life. A change of 2 to 3 points in the score is likely to represent a meaningful change in a person's quality of life. Almost all the patients enrolled in CheckMate-9ER, 93%, completed the questionnaires at the start of the study. Then they completed additional questionnaires at least every 6 weeks over the course of the study. The questionnaires were often collected during treatment and at follow-up time points. At least 75% of patients continued to complete the questionnaires until week 103 for patients in the CABOMETYX plus OPDIVO arm and week 79 for those in the sunitinib arm. From the chart here, you can see that CABOMETYX plus OPDIVO, the mean FKSI-19 score was numerically maintained near baseline for over 1.5 years. The secondary analysis looked at a specific subscale of the FKSI-19 questionnaire. This subscale looks at disease-related symptoms. Patients responded to statements such as, "I have a lack of energy," or "I have shortness of breath." Here you can see that with CABOMETYX plus OPDIVO, the mean score numerically increased and remained above baseline after week 7 for 1.5 years. Analyses of these data were exploratory, so we're limited in drawing scientific conclusions. However, based on my experience with patients and our discussions, these data are encouraging.
One last consideration is dosing. Marie is an older patient. With her comorbidity, she's probably taking other medications. If it's possible to keep the dosing straightforward, I like to do that. Per the trial guidelines for toxicity, CABOMETYX is always a 1-tablet dose, even if dose adjustments are needed, either from 40 milligrams to 20 milligrams or from 20 to 20 milligrams every other day. And most patients who needed a dose reduction only needed 1 dose reduction. Doctors and office staff appreciate single-tablet dosing of CABOMETYX. Furthermore, the overall efficacy results of CheckMate-9ER trial were achieved even when dose adjustments were needed. There is also a low discontinuation rate of CABOMETYX alone at 8% due to adverse reactions. And as a final endorsement for our treatment choice, the NCCN has given CABOMETYX plus OPDIVO a Category 1 recommendation for patients of all IMDC risk groups, favorable, intermediate, and poor risk in the first-line treatment of clear cell renal cell carcinoma. And it's also a preferred regimen for non-clear cell renal cell carcinoma with a Category 2A recommendation.
So taking all the data and all the evidence together, I'd feel very comfortable recommending CABOMETYX plus OPDIVO for Marie. There's compelling efficacy, and the results from the initial analysis have been borne out by the latest long-term follow-up data. I feel comfortable with the safety profile, and I find the quality of life data compelling.
I agree. CABOMETYX plus OPDIVO is an appropriate choice for a patient with multiple comorbidities and multiple sites of metastasis like Marie, who has metastasis in her lungs, liver, and bones. And the NCCN recommendation as a preferred category supports that choice.
Well, thank you so much for taking the time to talk about this case today. I really appreciated hearing your insights.
Thanks. I feel the same way. Hopefully others have found this to be helpful too. And stay tuned for the next patient management discussion in the CABOMETYX and Conversation video series.
Important safety information, warnings and precautions. Hemorrhage. CABOMETYX can cause severe and fatal hemorrhages. The incidence of grade 3 to 5 hemorrhagic events was 5% in CABOMETYX patients in RCC, HCC, and DTC studies. Discontinue CABOMETYX for grade 3 to 4 hemorrhage and before surgery. Do not administer to patients who have a recent history of hemorrhage, including hemoptysis, hematemesis, or melena. Perforations and fistulas. Fistulas, including fatal cases, and gastrointestinal GI perforations, including fatal cases, each occurred in 1% of CABOMETYX patients. Monitor for signs and symptoms, and discontinue CABOMETYX in patients with grade 4 fistulas or GI perforation. Thromboembolic events. CABOMETYX can cause arterial or venous thromboembolic events. Venous thromboembolism occurred in 7%, including 4% pulmonary embolism, and arterial thromboembolism in 2% of CABOMETYX patients. Fatal thrombotic events have occurred. Discontinue CABOMETYX in patients who develop an acute myocardial infarction or serious arterial or venous thromboembolic events. Hypertension and hypertensive crisis. CABOMETYX can cause hypertension, including hypertensive crisis. Hypertension was reported in 37%, 16% grade 3, and less than 1% grade 4 of CABOMETYX patients. In CABINET, N equals 195, hypertension occurred in 65%, 26% grade 3 of CABOMETYX patients. Do not initiate CABOMETYX in patients with uncontrolled hypertension. Monitor blood pressure regularly during CABOMETYX treatment. Withhold CABOMETYX for hypertension that is not adequately controlled. When controlled, resume at a reduced dose. Permanently discontinue CABOMETYX for severe hypertension that cannot be controlled with antihypertensive therapy or for hypertensive crisis. Cardiac failure. CABOMETYX can cause severe and fatal cardiac failure. Cardiac failure occurred in 0.5% of patients treated with CABOMETYX as a single agent, including fatal cardiac failure in 0.1% of patients. Consider baseline and periodic evaluations of left ventricular ejection fraction. Monitor for signs and symptoms of cardiovascular events. Withhold and resume at a reduced dose upon recovery, or permanently discontinue depending on the severity. Diarrhea. CABOMETYX can cause diarrhea, and it occurred in 62%, 10% grade 3 of treated patients. Monitor and manage patients using antidiarrheals as indicated. Withhold CABOMETYX until improvement to less than or equal to grade 1. Resume at a reduced dose. Palmar plantar erythrodysesthesia, PPE. CABOMETYX can cause PPE, and it occurred in 45% of treated patients, 13% grade 3. Withhold CABOMETYX until PPE resolves or decreases to grade 1 and resume at a reduced dose for intolerable grade 2 PPE or grade 3 PPE. Hepatotoxicity. CABOMETYX in combination with nivolumab in RCC can cause hepatic toxicity with higher frequencies of grades 3 and 4 ALT and AST elevations compared to CABOMETYX alone. With the combination of CABOMETYX and nivolumab, grades 3 and 4 increased ALT or AST were seen in 11% of patients. Monitor liver enzymes before initiation of treatment and periodically. Consider more frequent monitoring as compared to when the drugs are administered as single agents. Consider withholding CABOMETYX and/or nivolumab, initiating corticosteroid therapy, and/or permanently discontinuing the combination for severe or life-threatening hepatotoxicity. Adrenal insufficiency. CABOMETYX in combination with nivolumab can cause primary or secondary adrenal insufficiency. Adrenal insufficiency occurred in 4.7%, 15 out of 320, of patients with RCC who received CABOMETYX with nivolumab, including grade 3, 2.2%, and grade 2, 1.9% adverse reactions. Withhold CABOMETYX and/or nivolumab and resume CABOMETYX at a reduced dose depending on severity. Proteinuria. Proteinuria was observed in 8% of CABOMETYX patients. Monitor urine protein regularly during CABOMETYX treatment. For grade 2 or 3 proteinuria, withhold CABOMETYX until improvement to less than or equal to grade 1 proteinuria. Resume CABOMETYX at a reduced dose. Discontinue CABOMETYX in patients who develop nephrotic syndrome. Osteonecrosis of the jaw, ONJ. CABOMETYX can cause ONJ, and it occurred in less than 1% of treated patients. Perform an oral examination prior to CABOMETYX initiation and periodically during treatment. Advise patients regarding good oral hygiene practices. Withhold CABOMETYX for at least 3 weeks prior to scheduled dental surgery or invasive dental procedures. Withhold CABOMETYX for development of ONJ until complete resolution. Resume at a reduced dose. Impaired wound healing. CABOMETYX can cause impaired wound healing. Withhold CABOMETYX for at least 3 weeks prior to elective surgery. Do not administer for at least 2 weeks after major surgery and until adequate wound healing. The safety of resumption of CABOMETYX after resolution of wound healing complications has not been established. Reversible posterior leukoencephalopathy syndrome, RPLS. CABOMETYX can cause RPLS. Perform evaluation for RPLS and diagnose by characteristic finding on MRI any patient presenting with seizures, headache, visual disturbances, confusion, or altered mental function. Discontinue CABOMETYX in patients who develop RPLS. Thyroid dysfunction. CABOMETYX can cause thyroid dysfunction, primarily hypothyroidism, and it occurred in 19% of treated patients, 0.4% grade 3. Assess for signs of thyroid dysfunction prior to the initiation of CABOMETYX and monitor for signs and symptoms during treatment. Hypocalcemia. CABOMETYX can cause hypocalcemia, with the highest incidence in DTC patients. Based on the safety population, hypocalcemia occurred in 13% of CABOMETYX patients, 2% grade 3 and 1% grade 4. Monitor blood calcium levels and replace calcium as necessary during treatment. Withhold and resume CABOMETYX at a reduced dose upon recovery, or permanently discontinue CABOMETYX depending on severity. Embryo-fetal toxicity. CABOMETYX can cause fetal harm. Advise pregnant women of the potential risk to a fetus, and advise females of reproductive potential to use effective contraception during treatment with CABOMETYX and for 4 months after the last dose. Adverse reactions. The most common, greater than or equal to 20% adverse reactions are CABOMETYX as a single agent, diarrhea, fatigue, PPE, decreased appetite, hypertension, nausea, vomiting, weight decreased, and constipation. CABOMETYX in combination with nivolumab, diarrhea, fatigue, hepatotoxicity, PPE, stomatitis, rash, hypertension, hypothyroidism, musculoskeletal pain, decreased appetite, nausea, dysgeusia, abdominal pain, cough, and upper respiratory tract infection. Drug interactions. Strong CYP3A4 inhibitors. If co-administration with strong CYP3A4 inhibitors cannot be avoided, reduce the CABOMETYX dosage. Avoid grapefruit or grapefruit juice. Strong or moderate CYP3A4 inducers. If co-administration with strong or moderate CYP3A4 inducers cannot be avoided, increase the CABOMETYX dosage. Avoid St. John's wort. Use in specific populations. Lactation. Advise women not to breastfeed during CABOMETYX treatment and for 4 months after the final dose. Hepatic impairment. In patients with moderate hepatic impairment, reduce the CABOMETYX dosage. Avoid CABOMETYX in patients with severe hepatic impairment. Please see accompanying full prescribing information. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088.